Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Eric Schneider of Tennessee Retina. Welcome back to Retina Synthesis, Eric.
Thanks, Carmen. Happy to be here.
So, today we're going to talk about the PHOTON trial, which was the high dose Aflibercept study of diabetic macular edema. And you presented the long term results of this study at the ASRS. Can you tell us first of all, how the photon study was designed and what its goals were?
Yeah, the original Photon study involved the enrollment of patients with center involving diabetic macular edema. In that trial, patients were randomized 1 to 1 to receive aflibercept 2 milligrams every 8 weeks, and that's with 5 monthly loading doses, or aflibercept 8 milligrams every 12 or 16 weeks, and that was with 3 monthly loading doses. Obviously, the purpose of the study was to seek approval for aflibercept 8 milligram for the treatment of diabetic macular edema. If you look at the specific patients who were recruited in this trial, they had relatively modest DME with a CST of at least 300 and visual acuity in the 2032 to 2320 range. The study that I presented at ASRS was the long-term extension of the original Photon study. And as the name implies, this was an extension of the original Photon study. Patients were given the option to enroll in an extension study. However, there was a bit of a change with the extension study. The patients who were originally treated with aflibercept 2 milligram were actually transitioned to aflibercept 8 milligram, and that was dosed initially every 12 weeks. And it's important to note there were no additional loading doses administered to that group, so sort of a switcher group. And then the patients who were initially treated with aflibercept 8 milligram were continued at the 8 milligram dose at their last assigned dosing interval. Patients were seen every 12 weeks for their mandatory visits or checks, but there were PRN visits based on treatment visits. And the other thing that's important to note is that similar to Photon, patients could have their dosing intervals shortened or extended. In this case, though, it was by 2 week intervals as opposed to 4 weeks in Photon. And that was if they met specific shortening or extending criteria that were based in the protocol.
So, what were the findings?
Yeah, so if you look at let's start with maybe the functional outcome. So if you look at the photon and photon extension functional data, we see that during photon, patients in both the 2Q8 as well as the 8 milligram arms did achieve very significant and quite similar visual acuity gains, gaining around 7.2 to 7.9 letters by week 96. And when you look then at the next 60 weeks in the photon extension, we see that those visual acuity gains were largely maintained. So at the end of week 156, the visual acuity gains were about 6.5 and 7.2 letters. But what I think is really striking about the extension is that there was a pretty dramatic decrease in the number of injections. So they were able to maintain these functional gains with less injections. So if you look at, say, the annualized injection rate, so during photon with 2Q8 dosing, there was about 7.5 annualized injections, which dropped to 3.8 annualized injections in the extension. And that's obviously with the switch from two milligram to 8 milligram. And if you look at the 8 milligram group, the patients who were continued on 8 milligram throughout the full 156 weeks, they went from about 4.8 annualized injections in photon down to 2.9 in the photon extension. So I think it just shows the power and the durability of 8 milligram as compared to 2 milligram. Uh,
Yeah, Matt Starr from the Mayo Clinic published a paper in Review of Ophthalmology recently talking about undertreatment of diabetic macular edema, which is remarkable. Looking at the clinical trial data, where on average the patients were treated 8 times a year, on average in the IRIS study, patients were treated 4 times a year. So decreasing the treatment burden will improve compliance, don't you think?
Yeah, I think it's definitely a huge issue. I think what, I hear from my patient, I think, colleagues around the country, the common refrain is that it's challenging to get these patients, especially, the diabetic patients who are working age, right? They have jobs, and there's a significant cost to them to come to these visits. And then many people rely on family members for rides. Let's say they're getting bilateral injections. And so transportation can be a challenge. And so the less we can bring people in, I think certainly the higher the compliance is. I think, patients are very happy to come every 3 or 4 months. When they're required to come monthly, it's a much harder sell. I think that's when we end up losing patients to follow up, is when, they've either lost their ride or they've run into trouble at work. And so I think, Matt's work is incredibly important to highlight. And hopefully with some of these newer agents, we can really tackle that problem. Under treatment is no longer, 4 injections is actually over treatment if you look at some of the photon data, right? So if we get these better agents, I think will really help tackle that problem.
How do you use 8 milligrams in diabetic macular edema in the real world, Eric?
Yeah. That's a great question. I think, myself, like many, oftentimes start with some of our harder to treat patients. And so obviously 8 milligrams now been out for, almost 2 years now. And so we have a lot of experience with it. But I think initially I used it on some of these real refractory patients who were difficult to treat. And I think that really showed the incredible drying power of aflibercept 8 milligram. But I think as I got more comfortable with the profile, both from a safety perspective as well as an efficacy perspective, I really transitioned to using it more as a first line agent. And that's where you really see, I think, the durability, right? I have, patients out who are out, 16, 20, even 24 weeks, right? That gets into the question of when do we stop treating patients? But, given if you look at the clinical trial data, many of these patients, upwards of 88% in the continued 8 milligram group were on 12-week dosing, with about 50% on 20-week or greater dosing. And so I think what that provides is some stability. I think we've seen some recent data about fluctuations in CST resulting in worse visual outcomes. And so I think even at these long intervals, and there's some benefit. And the other benefit is also, if you think about these patients who are you're off therapy, to come back with worse, NPDR or progress to PDR. And so I think we're controlling the DME, but I think we're also helping control the diabetic retinopathy. And so I've really transitioned to using it as a first line agent as well, just because of that ability to rapidly extend patients. I think that's the other thing, as compared to 2 milligram or other sort of first generation agents, is I'm much more comfortable extending this, 3 or 4 weeks at a time, as opposed to 1 or 2 week extensions. And I think that's also been a great benefit to patients as well.
Do you use loading doses?
I do use 3 loading doses. Obviously it depends on the extent of the edema. I am still one who, hews to not treating patients with good vision if they have center involving DME. So if they're 20/20. So those sorts of very mild patients, they probably get away without loading doses. If I were to treat those patients. But in general, I like to load 3 times and then extend. One of the things about the label for aflibercept 8 milligram is there's sort of a built-in extension after those 3 loading doses. And so I tend to take advantage of those 3 monthly doses just to really, reinforce any gains I get with the first injection.
So when do you see them after the 3 loading doses? When's the first visit?
Yeah. So I typically I do, yeah, 3 monthly doses, and I typically go 7 to 8 weeks, right? Obviously a lot of the places I go, the schedule can be not a weekly, but maybe bi-weekly, or sorry, every other week schedule. And so I typically would say 7 to 8 weeks, and then would extend if they look great, then somewhere between the 2 to 4 week range, again, depending on, the patient's other eye and the extent of initial edema.
What about faricimab?
Yeah, I think, similar results with faricimab. I think another, excellent second line agent. In terms of that, I also load, with 3 monthly loading doses, and will then extend, again, 2 to 4 weeks at a time. In terms of the comparative, efficacy of those agents, there's no real solid clinical evidence. I think anecdotally, I feel that some patients do better with one agent versus another, right? I think there are individual probably differences that we don't quite understand in terms of patient response to therapy. And so I'm certainly have switched back and forth between those agents for different patients, and have found some have done better on one versus another.
Do you consider using bevacizumab in patients with relatively good vision?
I certainly do, and obviously we're oftentimes required to use bevacizumab more and more these days. From a step therapy perspective. I think if you look at some of the data looking at, for instance, the DRCR protocol where patients were initially treated with with bevacizumab and then could switch to aflibercept 2 mg. Obviously the visual outcomes were the same in the patients who were initially treated with bevacizumab as compared to those who were initially treated with aflibercept 2 mg. However, 75% of the patients required switching. And so it's not only just the final vision we have to consider, say at a single time point, say at 2 years. If the patient's vision was worse for a good chunk of that 2 years because they were waiting to switch, I think there's a negative, sort of functional aspect to that that's really not captured when we look at that. And so, I try to use, I think the best agent I think will work best for a patient. But sometimes that is bevacizumab. I think, as we've encountered some issues with, patient assistance programs lately too, we've had to transition more to bevacizumab. And, for many patients, it works pretty reasonably, particularly if they're willing to come in maybe a week or two sooner, or, depending on the agent you're using, I think that could be a reasonable option.
Well, it's wonderful that we have so many options available, and the treatment burden has substantially decreased with aflibercept 8 milligrams. Thanks for your participation in retina synthesis, Eric.
Thanks for having me, Carmen. It was very enjoyable. Take care.